Hi, I'm Tom Marino. At Cohn-Resnick, we believe that all citizens need to be informed about the issues that affect their daily lives. That's why we're proud to support the programming produced by Caucus Educational Corporation and their partners in public television.
The changing world of healthcare, next on Caucus, New Jersey.
Funding for this edition of Caucus, New Jersey has been provided by Activis, New Jersey Sharing Network, dedicated to saving lives through organ and tissue donation. Berkeley College, the Healthcare Foundation of New Jersey, the Adler Aphasia Center, and by the Russell Berry Foundation. Promotional support provided by NJ Biz, All Business, All New Jersey, the Star Ledger, powering NJ.com, and by New Jersey Monthly, the magazine of the Garden State, available at newsstands.
Welcome to Caucus, New Jersey. I'm Steve Adubato. You know, the model of healthcare is clearly evolving. Many hospital systems across the country are looking for new ways to elevate the quality of healthcare while reducing cost. Here in the studio to help us better understand healthcare changes happening in New Jersey and nationally are Bob Garrett, President and CEO, Hackensack University of Health Network, and finally, we also have his colleague, John Lloyd, President and CEO, Meridian Health. Now, I call you guys colleagues because there's an interesting partnership that has evolved. Now, John, describe where your hospital network is, and then Bob, I'll give you a chance, because now your partner's in a very interesting alliance.
Yes, Steve, Meridian Health is in Monmouth and Ocean counties, and we have a group of 6 hospitals and a lot of non-hospital services like home care and nursing homes. So we're in about 90 locations throughout Monmouth and Ocean County, and probably about 40% of the market.
Bob.
And Hackensack University Health Network, Steve, is located in northern New Jersey. There are 4 hospitals within our network, and like John, we have many ambulatory care centers that really serve the entire northern New Jersey, southern New York region.
So in this incredibly challenging environment where we talked about in the opening, many hospitals are clearly looking to maintain, expand, improve quality, but deal with costs. Something called Allspire Health Partners has been created. What is it, Bob, and why does it bring the 2 of your systems together along with the Atlantic system as well? Go ahead.
Right. It's an alliance, Steve, of 7 major health systems that are located throughout New Jersey and Pennsylvania. In New Jersey, it's Hackensack University Health Network, it's Atlantic Health System, and Meridian Health.
Right.
In Pennsylvania, it's Lancaster, Lehigh Valley, Reading, and WellSpan. And it's an exciting alliance because it takes 7 major systems and brings them together to really share best practices to improve health and health outcomes, and hopefully can provide health care more efficiently by sharing those best practices with one another.
Let's break that down, because it sounds like no one would be against that, John, but from a patient perspective, best practices, sharing costs, doing more with less, but concrete example, what would that mean to patients?
Well, one of the things we want to do is share best practices from a clinical viewpoint. All of our health systems have high-end programs such as cardiac surgery, great cancer programs, neurosciences, pediatric hospitals, and just a whole litany of really high-end, outstanding clinical programs. So one of the things we share in common is we each have sort of our own distinct clinical programs. So at Hackensack, obviously, they have a great cancer program, or one of the hospitals.
John Thur Cancer Center, which is
right.
huge. So they're marketing that, promoting that. You're doing the same thing at Meridian.
We're doing cardiac surgery. We have the Canadian Children's Hospital as well, and we're also very focused on innovation. So aside from some of the things we can do today to help patients, the whole notion of innovation under health reform is very important to all of our organizations. So a lot of things we see that we can do together to share best practices and to really accelerate the rate at which each of us can develop better clinical programs.
What does it mean share, though, Bob?
Well, what it means is really getting our clinical people together and saying, okay, this is how we did it. This is the outcomes that we've achieved. So as an example, all 7 health systems have been ranked either regionally or nationally.
Now, by the way, be clear, sorry for interrupting, Bob. Pennsylvania and New Jersey, because we have an audience in Pennsylvania. it's not just the 3 in New Jersey.
It's the 4 in Pennsylvania as well.
Got it.
So each of those 7 systems have been ranked either regionally or nationally by U.S. News & World Report for having good quality care and great outcomes. So one example, you mentioned Hackensack and the John Theurer Cancer Center. Hackensack is in the process of becoming NCI designated, National Cancer Institute designated comprehensive cancer center. With that will be new research protocols that will be available to our cancer patients. We hope that we can then export that to our Allspire Health partners as well.
Export it?
Export it meaning that allow access to those clinical protocols, those clinical trials to the other systems.
Right.
So residents in Monmouth and Ocean and surrounding areas that would tend to go to your hospital, or Meridian hospitals, would then have access to?
They would have access, but again, the geographic distance, from a practical viewpoint, they're more likely to stay in their local market. But certainly, it would be available to them to go elsewhere. But another example is one of the health systems in Pennsylvania. They have a world-class diabetes program.
Right.
That's something they can share. At Meridian, we actually have one of 4 demonstration pilots in the country related to end-of-life or palliative care. And we've been at that 15 months, and we've had great results. So we can share that with the other 6. And we have many, many examples where by sharing with each other, we can accelerate the degree of excellence in clinical areas. We can accelerate us developing those excellent areas.
Each of the systems also are well known for their patient experience, meaning that they excel at giving patients the best possible experience. And you know what? There's a way that we can share that information with each other, I think, to improve the overall care that's rendered to patients. Then on the economic side,
let's talk the financing, because that's a big part of this.
Yeah, so on the economic side, there are some obvious efficiencies that we can maybe achieve. As an example, if we all purchased our goods, our services, our capital equipment together, maybe there would be better pricing that could be obtained, and ultimately the consumers will benefit from that because that will be passed on to the consumers.
Let's play this out for a second, because if you live anywhere in New Jersey or in this area, you're used to seeing big ads, full-page ads, half-page ads,
right,
promoting your respective systems, other systems that are well-known, not just to folks who watch this program, because we're fortunate enough to have underwriters from a lot of different systems, but whether they are or not, you see these ads. And so I'm thinking to myself, these are competitors who are now saying, okay, I know we're spending a lot of money on marketing and advertising and branding ourselves, distinguishing ourselves,
right,
John Lloyd, and now we're going to say, you know what? But together, in this partnership, we can save money, share information. Isn't that somewhat counterintuitive?
We are competitors to some degree. I think the good news is we don't compete directly head-to-head in our own markets. And so there is a degree of non-competitiveness, which is very important. And another great example would be we all have our own employee health plans. We're all self-insured, all 7 of us. It's a great opportunity for us, and we plan to share how are we doing? How are each of us doing in terms of the quality of care we're providing to our employees or team members? How are we doing in terms of the cost? And there's so many examples just by sharing.
Pooling resources?
Absolutely. Pooling the intellectual brain power of the group, pulling clinical excellence.
What's been the reaction? I'm sorry for interrupting, John. What has been the reaction of certain team members? Because I imagine there's a degree of pride in our place, right? Our institution, our program. And the executives have gotten together. And by the way, Joe Trumfrio from Atlantic is the 3rd CEO, at least on the New Jersey side, right, that is part of this. But I just want to be clear to disclose that piece of the equation. But it's one thing to have the executives come together, which must be challenging enough to hammer out an alliance partnership like this. But when you're pushing that down, big change like that, I imagine it's an interesting dialogue, to say the least, Bob.
It has been, but I have to tell you, the reaction has been tremendous, very, very positive. The clinical leaders can't wait to get together and start sharing best practices, because that's what they're trained to do. I mean, part of their mission is not only to take care of patients, but to really spread best practices and share information. So I have to tell you, there's as much enthusiasm I've seen on the clinical side as there is on the administrative side.
No pushback.
No pushback in our place.
Same in our organization. People are excited.
Yeah.
We've made it clear that it's an alliance and not a merger.
So not a merger, so no plan, I'm going to be clear, no plan, hey, we're going to be letting go of this number of people, reduction in staff.
No, that's unrelated. Each of us are dealing with our own cost issues within our hospitals. Those kinds of issues are going to be dealt with individually. But on a broad basis, it's important that people understand it's not a merger.
It's not a merger.
As soon as you say a merger, there's a lot of paranoia, concern. Am I going to lose my job?
John, what happens as soon as you say, you know what, how about this? Because communication, our business,
Right.
you know, message sent doesn't always equal message received. Hey, I hear that Meridian's merging with Hackensack. And you say, no, that's not what we said. We have an alliance, it's a partnership, but people hear what they want to hear. Haven't you had to make that clear?
We've made that very, very clear from the beginning. It's not a merger. There is no assets being changed. This is simply an alliance to share best practices for each of us to get stronger in our own markets. And to pick up on John's point before, the geography is so unique because we complement one another. We don't compete with one another. And I think that's what makes it unique. Yet we're still in the same overall geographic area. So there's some synergies, there's some efficiencies that can be achieved without competing head to head. So this is really, and there's been other shared service models that have been set up throughout the country, but this not only is the largest, but I think it's the most exciting because of the geography and because of the quality of the systems involved.
Jump back in, John.
Yeah, I was going to say, I mean, we have about 25 hospitals that are part of Allspire. When you combine all the hospitals. If you look at the population, we cover like 6 million people in the population in terms of our service areas. So it's a unique opportunity, and I think the way all of us are looking at it is shame on us if we don't do something significant. And
what does that mean, shame on you?
Shame on us. I mean, we're putting together something very unique and innovative. And if we blow this opportunity, shame on us for doing it.
And the industry, let's ask this question. By the way, we're going to be shifting gears in just a minute after we take a break to talk about some very bigger, no, I'm not saying bigger picture, but talk about the impact of Obamacare, the lack of primary care physicians, the relationship between hospitals and physicians, which is evolving dramatically. But I'm asking you this, industry-wide, across this country, to what degree are you getting a reaction in response to what you're doing? There
is tremendous interest, and there are a few other organizations that have established themselves as an alliance or a collaborative. You know, years ago, when this was tried, it didn't work very well. I think today...
It was tried?
Absolutely. If you go back 5, 10, 15 years ago, and they turned out to be just a sort of a collection of interested hospitals. They really didn't do much. We're very different. We're very focused. We've already vetted all kinds of ideas. We're going to have a set of priorities. We're probably going to have 5 or 6 priorities we're going to work on, some business and some clinical, and we're going to get to work. And shame on us if we can't do something great. We're all motivated to share best practices. We're all motivated to reduce cost, you know, and if there are ways we can do it on the business side and the clinical side, it's going to be a home run.
Yeah, I think what makes this one different from some of the others that have been tried is that we really do have a very specific plan, a specific agenda. So, you know, there's been others out there in the country that, you know, they announce an alliance, they announce a partnership, but they really, it's been a name only. They really haven't even figured out what they want to do. And we've, as John said, we've prioritized. We have 5 or 6 major priorities that we're going to be announcing in the coming weeks and months to roll out. And the shame on us really is, you know, look at it. I mean, we're charged. Part of our missions are to improve the health care of the populations that we serve. So shame on us for not taking this opportunity to really get that done on a region-wide basis. Think about that. That really hasn't been done anywhere.
In a region outside of the state. Well,
I could just add to that real quick.
Quick point.
There's so much momentum now because of health reform.
Well, I'm going to ask you that, John.
Okay.
If the Affordable Care Act had not been passed, do you believe you'd have this partnership? Would Allspire exist if it were not for the Affordable Care Act?
I'm not sure we would.
You think it was pushing, it has pushed Allspire to be...
I don't think the Affordable Care Act itself pushed it. I think it was the environment. Whether we had Obamacare or not, the whole issue was things had to change. Healthcare is too expensive, too fragmented. So we were all...
Something had to happen.
We've all been pushing our organizations nonstop for the last 3 years.
To
transform the way we deliver care. Transform it. Make it better for the consumer. Make it better for a health population, and also the
and
lower
contain costs.
No,
final comments before we take a break.
No play on words, but the Affordable Care Act inspired Allspire.
Oh, let me ask you this.
I've been waiting 5 minutes to say that.
Is it only 5 minutes, or did you plan that for public television for weeks? Okay. Folks, we're going to take a quick break. When we come back, we'll talk to Bob and John. I'm not going to say bigger picture, because this is a big picture discussion already, but I do want to ask the question, what happens with Obamacare in terms of its impact on these hospitals, other hospitals? Because it's no secret, as we do this program, there are some challenges that the federal government is facing, and it's going to affect a lot of folks across this country. We'll be back right after this.
If you would like more information on this program, or if you'd like to express an opinion, email us at info@caucusnj.org. Visit us online at caucusnj.org, or find us on Facebook at facebook.com/Steve Adubato, PhD.
We're back. We're talking to two of the CEOs across this country that deal with hospital issues every day, Bob Garrett and John Lloyd. Let me ask you, Bob, the Affordable Care Act, as we do this program in the late fall 2013, lots of challenges. Let's hope the website, things work out. The president said clearly that if you have your plan and you like it, you won't have to change it. We know that that's not exactly what the case has been. Here's my question for you and John, as healthcare leaders, as hospital executives of systems. What has been the fallout for you and your colleagues? And can you sit there and call a timeout and say, well, you know what, we're going to not do anything until they get it all straightened out? Can you do that?
You really can't. I mean, I think you have to move ahead with the strategies that serve your system and the population that you serve. You know, I think the healthcare market has been changing and evolving naturally with or without the Affordable Care Act. I mean, in the first month, I heard the administration had originally anticipated 500,000 nationally folks signed up through the website, and the numbers came in at under 50,000. So obviously it's off to a slow start. But from a health systems perspective, the idea of improving care, managing the population health, those are concepts. Physician integration, physician partnership, those are strategies that would happen with or without the Affordable Care Act.
That's going to happen anyway. So I want to be clear, John. Bob says, listen, it's great if the federal government can improve the implementation of the Affordable Care Act, but it doesn't change what you're doing on your end? You agree?
I absolutely agree. When we look back to 2010, and it was unclear as to whether that law would or wouldn't be overturned legally, we pretty much decided it didn't matter. Healthcare has gotten to the point it's way too expensive, it's too fragmented, and no one is going to allow it to go forward in the form that it was before, where it was very costly and fragmented. So all of us, you know, we were aware of Obamacare, we were aware of the legislation, but we didn't become obsessed by it. We put our nose to the grindstone, and for 3 years at Meridian, all we did was to learn how we can transform the way we deliver care. And that's what we've been doing.
So physicians.
And even if the exchange doesn't get fully implemented, it doesn't deter us. We're full speed ahead on our initiatives.
So I think just to add to what John said, I think it has enabled us to move forward with our agendas quicker. So as an example, and I know you wanted to ask about physicians.
I'm fascinated by the relationship that's evolved between physicians and hospitals, hospital systems as well, because I know it's not the same.
Right. So in the past, physicians and hospitals, if you will, competed with one another. Now they are really collaborating. They're aligning. Physicians are being employed by major
More
health
so than
systems.
ever.
More so than ever. And I think the anticipation, even before the Affordable Care Act went into effect, the anticipation of it really led both hospitals and physicians to really take a serious look at that. And you know what? It's the right thing to do. It's the right thing to do for patients, for patient care.
What does it benefit to patients if a physician is now, quote unquote, an employee of a hospital versus that physician out on his or her own affiliated with a hospital? What's the difference?
There's clinical integration. There's alignment between the physician and the hospital, so everybody is on the same page. There's no difference in terms of economic motivations, economic competitiveness. Everybody's really speaking the same language. They're on the same page, and the focus, where it should be, is on the patient.
You agree, John? It's better for the patient if more physicians are tied directly to hospitals, employed by hospitals?
I'm going to take a slightly different view.
That's what partnerships are about.
I don't really. I don't totally.
There's enough room under the tent.
I don't totally disagree with Bob.
Go ahead. I want to hear this.
And we're very similar. Prior to all this, we had probably 80% of our physicians at Meridian, and we have 2,200 physicians, were independent. Today, that number is probably, I don't know, maybe it's 75% instead of 80. So we've had more physicians come forward. In our organization, we respect the right of the physicians to be independent. And we have a pluralistic model. And many physicians do not want to become employees. And over my career, I have always said, if you want to be independent, great, I want to work with you. If you want to be part of our employed physicians, that's fine. What's happening now is more and more physicians, particularly the smaller practices, they can't be successful on their own financially.
Then the reimbursement isn't right. The reimbursement is what it is. The regulations are the overhead. So they want to be more and more want to work for you.
So we're going to converge to the same point, Bob and I, because physicians are coming to us at a high rate in terms of
out of need.
Please help me. Please help.
And your attitude about that is?
Fine. Our attitude is if a physician wants to remain independent, that's great. We want them part of our system. If they want to be employed, we'll do that as well. And we have various models. It's not just straight employment.
Right.
We pay very few physicians 100% on salary. Usually it's a base salary and incentives
hybrids
for quality, or at least we lease practices.
There are other ways that physicians and hospitals can work together without direct employment.
For example?
Accountable care organizations. So
ACOs.
That's ACOs.
Right.
So that's one of the centerpieces of the Affordable Care Act. So it's an organization where hospitals and physicians get together, and the idea is to better manage the overall health of the population.
Excuse me, interrupt me. Is it a separate? We had a Nicotino, who both of you know very
yes,
well, who is on, full disclosure, is on the board of the Caucus Educational Corporation. Both of you guys know well.
Right.
She's talked to us about accountable care organizations.
Yes.
I keep asking, is it a separate organization?
It's a separate organization. It certainly can be owned by hospitals and physicians. There are some that are just owned by physicians. But it's a separate organization that contracts for care with insurers, whether it be governmental insurers or private and commercial insurers. And the idea there is under the Medicare program, which is the shared services program, the idea there is to try to manage the overall population health of the Medicare subscribers to provide better coordinated care more efficiently.
But who's responsible? But then who's responsible then ultimately for the care of that patient?
Well,
is it the accountable care organization?
Yes.
Is it the hospital system?
It's the accountable care. And it's a legal structure. In our case, we have 45,000 Medicare lives that we're managing with our physicians. And what's going to happen is over a 3-year period, if we can reduce cost and improve quality, we're going to share in the savings with Medicare.
So the federal government rewards you for cost savings.
Under this demonstration
under the demonstration program. So we're in the same program, and in the first year of operation, our accountable care organization has demonstrated $14.5 million of savings. 50% of that goes back to the Medicare program, and the other 50% gets split between the hospital and the physicians.
Right. So there's incentive. I want to be clear. And by the way, Atlantic, the other hospital of the 3 in New Jersey, other hospital system of the 3 that are part of the Allspire Alliance, they were out there early on as well.
Oh yeah,
they were.
With
absolutely.
The accountable care organizations.
And they have a very large ACO.
Is it brand new? This accountable care organization initiative?
It's a couple years old. The Medicare program rolled it out about 2 years ago. There were 27 across the nation that were the original shared services programs, and now there's hundreds of them.
But Steve, here's the point I want to make. It's not so much about the accountable care organization.
What is it about, John?
What it is, it's about getting physicians and hospitals or health systems to collaborate.
If they don't, someone says, no, I don't want to be on my own, John.
That's fine. But guess what?
Can they survive?
No.
No, it's not fine then.
Well, if you're small on your own, no. If you're bigger on your own, you can probably survive. But if you're a small practice on your own in the future, it's going to be very, very tough. But having said that, I mean, the point is that we're trying to get into all these demonstration pilots with our physicians so we can learn. We need to learn how to integrate care. If we can't integrate care, we're not going to reduce costs and we're not going to improve quality.
Status quo is not an option, though.
Status quo is not an option.
So,
in terms of what John's saying with physicians, either, I think the smaller practices are not going to be able to survive. So whether they align with a hospital, either through employment, through an accountable care organization, or they might align with a bigger physician group. And be part of that group. I think it's just inevitable. And by the way, same is true for hospitals. I think the smaller community hospitals, it's going to be very difficult for them to survive on their own without aligning with others.
Guys, a minute and a half left. So someone watching anywhere in New Jersey or anywhere in the several states we're seeing says, you know what? I like my community hospital. It's in our neighborhood. I know the people there. They treat me well. That's where I want to go. That status quo may not be viable as well.
If you look over the last 4 or 5 years, we probably went from maybe 40% of the hospitals being in health systems to then 55%. Today, 70% of hospitals in New Jersey are part of health systems.
Part of a larger system, not a standalone.
Part of a health system, right. So today there may be 20 or 22 standalones.
But if you like your local community hospital, the way to enable it to survive is for that community hospital then to join a larger health system, and maybe there's some efficiencies there to allow it to continue to survive.
But if that, a few seconds left, if that hospital executive of that small system says, no, we want to make it on our own, that's it, that status quo, that the economics do not work based on your interpretation of it.
Exactly. I think it's going to be risky business.
Right. I agree.
Risky business indeed. Bob Garrett from Hackensack University Health and John Lloyd at Meridian. I want to thank you guys. This is complex stuff, but no one forced you to do these jobs.
Steve, you did a great job asking those questions.
Well, I don't know the answers, John. I just asked the questions. Thanks, guys, for joining us and trying to unravel all this. I'm Steve Adubato. We tried to make sense of this very complicated healthcare world, and this is an alliance, and there are a lot of others we'll talk about in the future. We'll see you next time. Thank you. Thank you, guys.
The preceding program has been a production of the Caucus Educational Corporation, celebrating 25 years of broadcast excellence, and 13 for WNET, NJTV, and WHYY. Funding for this edition of Caucus New Jersey has been provided by Activus, New Jersey Sharing Network, Berkeley College, the Healthcare Foundation of New Jersey, the Adler Aphasia Center, and by the Russell Berry Foundation. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area. Caucus New Jersey has been produced in partnership with TriStar Studios. This program has been made possible in part by New Jersey State Nurses Association.